Thank you, Steve, Sue, Krista, and Viva for pioneering the effort and for sharing the stories with us for how you take ownership of vital signs in such great energy. So I'm seeing some of you online have started to submit your questions. We have over 400 people registered on the webinar, so we ask that you type your questions with your name and organizations into the box on your lower right-hand corner. While you're doing that, let's set the stage by hearing from the reaction panel. First up is Peter Long, President and CEO of Blue Shield California Foundation, one of the key drivers of the original Vital Signs report and also the funder for the demonstration project you just heard about. Peter, you're up.
Great. Thank you very much, Claire, and thanks to all the panelists, and good afternoon or good morning to my fellow West Coast people. So just want to share a little bit about our journey, which this has been a journey. It started 6.5 years ago, our involvement in this work. And it was at a conference that one wouldn't think may have led us all the way to where we are today on this webinar. But I was asked to be a reactor, similar to today, at an Institute for Healthcare Improvement conference co-hosted by Health Affairs. And it was 25, the conference was made up of 25 of the most innovative healthcare systems in the country, sharing their work on how they had moved toward delivery system innovation and transformation. And so that was an amazing experience of listening to, pardon me for 1 second here. So, pardon me, it was an amazing experience to listen to these, the best in the class in the country, and have the realization that these folks were using different outcome measures, different evaluation techniques. And so I, before this crowd who was looking for me, I think, to be congratulatory on the day, raised some serious questions to say, if these are the best and brightest, so this was the Virginia Masons, the Theta Care, and Bell and Health, if they were all using different outcome measures, different evaluation techniques, how were we ever going to get to a standardized process of high quality care? So after that meeting, I came back. Well, actually, the other realization I had at that meeting was that this also explained why our work on transforming the healthcare safety net in California had been so difficult, that we struggled with exactly the same issue, which is how do you work with community health centers and domestic violence organizations to get them to transform the healthcare system when they're all using different outcome measures, different data systems, and different even ways of evaluating their success. So I came back both heartened in a sense that we were not alone in our challenges in the world, and a little bit depressed that the best and brightest that we were going to struggle unless we started to work on the system rather than just in the system, that we wouldn't actually make progress. So the first person I called was Michael McGinnis and said to him, Michael, are we ready for a national conversation around shared outcome measures? Because it feels like if we don't actually systematically move this process forward, that we won't actually make progress. We won't achieve the results that we're looking for. So Michael said he thinks so. Let's talk about it. And so we were able to start the process with the National Institute of Medicine at the time, and the National Academy of Medicine. So in that process, I think I just want to commend the committee, particularly Elizabeth and Steve who are here. So I think they had a brilliant realization rather than trying to over-specify the outcome measures and come up with 40 brilliant measures for the healthcare system, that they actually would look at the domains and take a step back and say, what's the domains or what are the categories of measures that we need? And I think that was a brilliant observation rather than adding to the burden of measurement and giving us yet another set of measures that we couldn't move forward, or actually just adding to the cacophony. They actually began to clarify it for us and make sense of it. What that did do, though, is leave the gap of do these ideas work in community, and can they actually work for populations? Can they work in Fresno? Can they work in Monterey? And so that's why we're excited to partner with the Public Health Institute to think about that work of how do you move from concept into the reality of what this could look like in community. And so I couldn't be happier with the work that we're hearing about today and that what was presented on this call. And what it leaves me with are, I'd just share 5 observations around why I think shared outcome measures are so important. The first being that it actually drives our action and attention towards things that will improve people's lives. You heard examples today of multiple examples, whether it's transportation or safety, of using this data to actually do work differently with different partners to improve the lives of people in California. I think that's the most important why we care about shared outcome measures. It's also important because it bridges the divide between individuals and population. We often have this divide between the public health community and the healthcare community, but having a shared set of outcome measures actually lets us to bridge that divide and think about it holistically of how do we actually improve health at both levels. Third, and I think Veva raised this, it allows us to have standardized comparisons for equity, for accountability, for competition, so that we can actually begin to look at these things on measures that matter. Fourth is actually the prerequisite to paying for healthcare differently or paying for health differently. Unless we have shared outcome measures, we're never going to be able to pay for health differently. This is a fundamental building block. It's the keystone to the bridge of value-based healthcare. So we as a foundation are all in. If you hear, these two projects actually mirror our future strategic direction, which is to work in community and put prevention in practice through a shared set of outcome measures, but also work on building out the population health ecosystem. So working on the system and how do you actually change what our shared outcome measures are. We believe it's only through that combination of working inside the system and in community and rethinking how we actually, the system exists, that we're going to achieve transformational results. So I'm thrilled that we've gotten to this point today, and I'm incredibly excited to see where this work goes forward. Thank you.
Thank you, Peter, for these amazing thoughts. I'm going to move us along here. The next up will be Elizabeth Mitchell, President and CEO of the Network for Regional Health Improvement, also a member of the Vital Signs Consensus Committee. She will give the flavor of the considerations of vital signs in a healthcare setting, which we will feature in future events. She will be highlighting the cost measures in particular in vital signs and the power of regional data. Elizabeth.
Thank you very much. I'm really pleased to be here, and I wanted to say that it was such a privilege to be part of the study committee, but I was tasked with what I would argue is chairing the hardest committee, which was that of implementation. And I would say that it is so encouraging to show that we have made progress on implementation. We identified key barriers, data, consensus, business models, but the key barrier was really leadership and who owns this work. And the leadership of Blue Shield, of IOM, of our California partners is really showing that this is possible. And I want to really underscore what Michael said at the beginning. The urgency of doing this work has only accelerated under MACRA. We are moving to value-based payment from the public sector and from the private sector, and we will be linking payment to performance. And to navigate this transition, we simply have to reduce the burden and complexity for physicians and increase the signal strength for what actually matters. I also am in the role of Vice Chair of PTAC, and we are looking for measures of improved health and cost. We're not talking about payment reform for payment reform's sake. We're really talking about achieving better care at lower cost. So one of the projects, significant undertakings we took on was measuring common total cost across communities. So we heard today about common metrics in a community. We took this and tried to do it across the country in different regions. And we really found that the key enabler of that work was shared data across the entire community and then selecting common metrics. We need to remember that we are here because there is a huge problem of affordability in this country, and years of quality improvement work and measurement have not resulted in better care at lower cost. And arguably, with quality flat and cost up, we are actually experiencing lower value care. So this is all done to achieve the aims of the country of increasing health while also reducing the cost burden. And we are not imagining this. The GAO came out recently with a study that really quantified this burden. And if you look at the annual average cost of quality measurement per physician at $40,000, we know that there is an opportunity to really not only reduce the burden on physicians, but reduce some of the costs in the system without compromising care or outcomes. We know, though, that as much as we talk about aligned measures, everyone likes aligned measures as long as you're aligning around their measures. So this really has to be about people really coming together and identifying shared priorities for their communities. And we know that this actually is possible because with support from the Robert Wood Johnson Foundation, we tested this in 5 regions across the country. We chose a common measure, total cost of care and resource use, developed by health partners and endorsed by the National Quality Forum. And this is one of the vital signs measures, total cost of care. And we really do believe, as the theme has been, that we are measuring what matters most. And we were testing whether this could be done, because when we talk about the healthcare balloon, this is the entire balloon. What is the cost, and are we impacting it? Now, this one of the most exciting, though seemingly simple, outcomes of this is that we actually have a benchmark to compare commercial all-payer costs across the country in different regions. And while these may look like not terribly significant variations, the implications here are really significant. For example, if the higher cost region just reduced spending by 2.5%, we're looking at potentially $200 million of savings a year just for those stakeholders. It also raises policy questions. We see here that Maryland has the lowest spend. We know that they have a global cap. Is that contributing to lower cost per capita? It starts to help us identify and isolate where opportunities are for improvement and change. And just as another interesting exercise, we compared commercial cost to Medicare spend in each of these regions, and it is an absolutely inverse relationship. So where in the communities where commercial costs are low, Medicare was high, and vice versa. So lots of insights to be gained, lots of lessons learned, and really it's about putting this data to use to improve care and affordability. I also want to just acknowledge that IHA in California, the Integrated Healthcare Association, has also been leading work. They just didn't participate in our benchmark because of some data differences. But again, we're talking about use of the data. Why does it matter that we have standard metrics? This measure set itself shows both utilization and price, so we are able to share it with physicians who are able to use it with their patients on making care decisions, understanding variations in their own care patterns. The demand for this information has been pretty incredible when it is shared in practice reports in the different regions. They don't have this information otherwise. As they enter into risk contracts, it will be essential to their success. So we know that there is a use for this, and really there are different levers to get at affordability between utilization and price. So really having this insight allows us to move forward. So some of the key takeaways, honestly, I wish I could have just inserted Steve's slide here because we had so many similar ones. But all of this work started with a common table with shared data. And so that really enabled this standard transparency and comparisons across regions. We had to get the data right or the measures would not have been accurate. And when you move into high-stakes measurement, you have to trust the data. So we were able to find efficiencies in ensuring the data was common and reliable. And really identifying barriers opens up dialogue. So if there was a data access barrier, we could work with health plans, work with employers, say, how do we solve this together? And it really enables each stakeholder to take ownership in a different way. We have employer purchasers using this data or wanting to use this data in network design. We have physicians wanting to use it in management of their referrals. There is so much utility of common measurement when it exists. And really, it also helps change conversations and enable new partnerships, which are going to be essential as we move to population health. So we know that when you bring physicians and employers together, it's the same population. The employees of the employers are the patients. So they want the same thing for both, and this enables common and shared strategies. But again, too many unaligned measures. We've got to make selections based on our priorities. Permission to use the data remains a challenge. Harmonizing that data, it is doable, but it must be taken on in a way that enables reliable, credible measurement. And it really comes down to shared resources and leadership. But we have regions around the country who are poised to do this work. It is entirely doable and replicable, and I think holds enormous potential for transforming care. Thank you.
Thank you so much, Elizabeth. We're looking forward to working with you more. This is an incredibly rich project. Next, we will hear from Alina Basu, taking a few minutes from the Academy, who's the director of the Roundtable on Population Health Improvement. She will be sharing some related resources from the Roundtable on Population Health Metrics, which resonates with the premise of vital signs in connecting healthcare and population health.
Thank you so much. All these presentations have been really, really exciting, and I would just add briefly that the Academy's Roundtable on Population Health Improvement has held a number of workshops that have explored the social determinants of health and the actions of many sectors of society to alter the conditions for health. And metrics are one of the 6 conditions of influence that the Roundtable has identified in its theory of change for improving population health. And I would just mention that the couple of workshop products that are featured in my 2 slides are really resonating very strongly with what we've heard from the proof of concept of the vital signs report in California. I would highlight the fact that the Roundtable's conversations noted that measures need to be authentically community-driven, and we certainly saw that in both Monterey and Fresno, that they need to be fit for the purpose. So the first question is, to what end these metrics? And we heard some very similar stories from Santa Cruz County that we heard in Monterey, from the work there with young people related to violence, and also some work with measurement in San Francisco as part of their Sustainable Communities Index. Again, looking to design metrics for a purpose rather than just pick things up as they're available. The additional 2 things that I'll mention from my slide are that metrics need to be relevant for action, and I think we've heard a lot about attention to that feature in the work from California. And finally, metrics need to be emerging from and informed by cross-sector collaboration. Obviously, the health sector can't do this work alone, whether it's healthcare delivery system or public health agencies. And on the second slide, I would just mention that the Roundtable's focus has been on measures that go beyond the clinical sector. And a lot of what we have covered, I think, aligns very nicely with the vital signs priority measures in healthy community and community engagement domains. And maybe I'll just mention one very brief thing, which is that in a workshop that we held on applying a health lens to decision making in other sectors, we heard from the Massachusetts Department of Transportation that talked about its Healthy Transportation Compact, which included a walkability metric, which of course is one of the related priority measures that's identified in the Vital Signs report. And they identified that measure in particular because they felt that it was informing their state on the health effects of transportation decision making. And I think I'll just close there and make sure that links to all of the relevant resources are included. Thank you.